It is my pleasure and honor today to introduce one of my very good friends and colleagues, Paul Dorian. Paul is going to speak today about a philosophical issue, which is what we have learned from where we go wrong. It's called Where We Have Been Wrong, the Virtues of Skepticism in Medicine. The reason Paul can talk about this is because he has been through many countries, lived in many areas, and has had several careers, which really has given him an overview of the medical world as well as the world. Paul is very insightful in this. Paul is a Transylvanian emigre of Hungarian descent who emigrated from Transylvania, which was Romania, in 1962, has lived in France, Canada, including both Quebec and Ontario, done his fellowship in the United States, has had lots of opportunity to see the world through many different lenses, through the lens of an immigrant, through the lens of a trainee in cardiology, through the lens of a fellow in cardiac electrophysiology, early on at the beginning of electrophysiology, through the lens of a clinician, through the lens of a clinical pharmacologist, and through the lens of an administrator as the director of cardiology in the University of Toronto. So Paul has had that opportunity, and his insight he's going to bring to us today. Paul. Before I go on to Paul, I'm going to ask Mr. Robert Marr to stand up. This lecture is given in honor of his parents, and Mr. Marr has donated generously in order to continue this lectureship. Thank you, Paul.
Thank you very much, Marty. It's a great pleasure to be here with friends and colleagues, and I owe a debt of gratitude to Mr. Marr and the Marr family for making this presentation possible. I'm aware of two things, actually. First, it's really nice to have this at hand, but not necessarily wear it, so please forgive me. It's nice to be with real-life people instead of being on a Zoom, and I'm aware that this is the first real-life Marr lecture since 2019, which seems like a lifetime ago. So it's wonderful to be physically present with friends and colleagues. I'm also aware that I'm in a line of outstanding world famous cardiologists, electrophysiologists, rhythm experts who've given this lecture before me. And I'm honored and humbled to be part of this extraordinary group of individuals. I'm going to spend about 45 minutes giving you a sort of a personal journey through data, if you like, leavened by, you'll see lots of quotes. I'm a quote collector. I am of the opinion, as you'll see over the next 45 minutes or so, that artists and writers in particular have more to say about clinical medicine and research than we think they do. Often they're much wiser. In fact, usually they're much wiser than we are. And we use that as an example. Obviously, this is not a comprehensive review of everything that I've learned, although according to my children and my grandchildren, I haven't learned much. It's a very personal kind of snapshot of a few things that I think are examples of areas where we perhaps should pause and slow down in our haste to intervene in various medical conditions, particularly as they relate to arrhythmias. Now, since I'm Hungarian, I'm allowed to define what a Hungarian is. And all Hungarians are by definition skeptics. And some, in fact, are cynical. I have a standing joke. If anybody can find me a person who is demonstrably a naive Hungarian, I will give you $100, no questions asked. So far, I've never been taken up on this. My first, and again, there'll be very limited number of examples mostly from my experience and work that I've done. Of course, this can be very widely applied. I think basic science is extremely useful. I don't want to mistake my sort of beliefs for the group. I think basic science has everything to teach us about mechanisms of disease, about understanding pathophysiology, about understanding normal physiology, the normal workings of the human and other organisms. But the case I would like to make is we have to be very careful before we uncritically assume that if an observation, particularly a therapeutic observation, is true in the lab, it's necessarily going to apply in human beings. Sometimes it does, but often it does not. Just as two examples, Gabriel Laurent in my laboratory, who's now professor of cardiology in Dijon in France, where they make really good wine and really good mustard, I spent about 7 years in our laboratory. We created an animal model of atrial fibrillation with rapid atrial pacing, no heart failure involved. It turns out to be a pretty reasonable model. It's akin to the cardiomyopathy model of ventricular pacing, but now in the atrium. We did some things to sort of increase the probability there would be atrial scarring and enlargement. And amongst other things, we investigated a whole bunch of potential therapeutic maneuvers to forestall or prevent pathological atrial remodeling in this particular model. And because polyunsaturated fatty acids were sort of the vogue, we decided to study this. We have 6 or 7 publications. I'm just going to give the bottom line of our observations. And we found that if you give mixed polyunsaturated fatty acids, fish oils, as you may use medically or over the counter, that is now a multi-billion-dollar industry. Fish oils are used for every possible disorder from eczema to heart disease. And we found that fish oils at the doses usually used in human beings prevented atrial fibrosis in our model of atrial fibrillation with inducible atrial fib in this animal model. And we further looked at the various components of fish oils. We found that eicosapentaenoic acid, as opposed to d-eicosapentaenoic acid, easily pronounced as EPA and DHA. Try this after 3 martinis and you won't be any better than me. That EPA did not, in fact, lead to prevention of atrial remodeling, but DHA, this is a component of fish oils that your patients are taking if they take fish oils, are in fact anti-fibrotic and anti-inflammatory. We showed that they also cause transcriptional changes with RNA microarrays. So we were pretty confident that DHA or mixed PUFAs were beneficial in preventing atrial fibrillation. Of course, they've been studied from many other contexts. I'm not going to talk about eicosapentaenoyl ethyl for the prevention of coronary events. We're just talking about atrial fibrillation. Beautiful theory, slain, unfortunately, by an ugly set of facts. This is a meta-analysis of all of the fish oil studies, randomized, blinded fish oil studies. I'm not talking about the REDUCE-IT trial. I'm just talking about atrial fibrillation now. So standard doses of fish oils. And here you can see the meta-analysis on the top. Perhaps the pointer will work here. You can see at usual doses, there's a slight increase in the incidence of and the burden of atrial fibrillation in all these blinded trials of fish oils. And when you look at higher doses, greater than 1 gram per day, in our animal models, we were looking at the equivalent of about 2 grams per day, sort of a high but clinically relevant dose of PUFAs. What works in the laboratory works in the opposite direction in human beings, where there's a relative increase in the risk of atrial fibrillation with PUFAs, overall risk of 1.3, 1.4. I think it's fair to say when you're talking to your patients who are maybe taking fish oil supplements that the absolute increase, we'll talk about absolute versus relative increases in some detail, the absolute increase is relatively small, but nevertheless, the opposite effect of what we expected from basic science is translated into clinical practice. My very first research project, this is not for this slide, this is a clinical study that we did at St. Michael's in Toronto. My very first research project as an EP fellow when I was at Stanford was working with implanted defibrillators, and I knew something about antiarrhythmics and I knew nothing about defibrillation. So I thought, well, I'll add 1 + 0 = 2, which is the math was a bit wrong. But anyway, I studied the effect of lidocaine on defibrillation. And what we showed in a series of papers, which I won't bother you with, is that lidocaine in experimental animals makes it more difficult to defibrillate. Its sodium channel blockers in general make it harder to defibrillate in experimental ventricular fibrillation, probably a consequence of conduction slowing and changes in the wavelength of conduction during fibrillation. The bottom line was, I left my fellowship thinking, Sodium channel blockers, lidocaine in particular, which is often used in patients who have or are at risk for ventricular fibrillation, are going to make it harder to defibrillate their bad drugs. So we did a small randomized clinical trial, which made it into a reasonable profile clinical journal. And we had a blinded randomized study of lidocaine versus amiodarone. This is very early days working with paramedics. We did the study in the 1990s, where we didn't have the horsepower, so to speak, to look at the best outcome, the important outcome in cardiac arrest, which is survival to discharge in hospital. You all know that if you have a cardiac arrest and you're in ventricular fibrillation, you have about a 50% or a 40% chance of transiently having the paramedics restore not sinus rhythm, but restore a perfusing rhythm, so-called ROSC, restoration of spontaneous contractions. Then you have some probability of making it alive to hospital, because not all of these people survive, and some people die in hospital and they're discharged alive. The best endpoint for these trials would be discharge alive from hospital, but we didn't have enough patients. So we looked at lidocaine, which we thought that was our hypothesis, was not as good as what was then an experimental drug for this condition, now widely used, which is amiodarone. This is starting in about 1990, and the randomized clinical trial showed that amiodarone was superior for all outcomes with respect to lidocaine, except we didn't have enough papers to look at survival to discharge. So that was 2002. Fast forward to about 2009, Resuscitation Outcomes Consortium called ROC, which I had the privilege of belonging to, a North American consortium, United States and Canada. We repeated this work in now about 4,000 patients, done in a same model, but in a much larger, better controlled patient population, amiodarone versus lidocaine in shock-resistant VF. And guess what? We get a completely different result. So our initial work, both basic science and limited clinical work, was incorrect. We find that now you can argue whether the P of 0.08 is statistically significant. There's lots of nuances. If you like, we can talk about that. If you look at the subgroup of patients who got intravenous antiarrhythmics as opposed to intraosseous antiarrhythmics, both amiodarone and placebo are significantly better. But the surprise here, and the point I'm trying to make, is when you do a large-scale randomized clinical trial, you sometimes find differences that are unexpected and go against the basic science and go against your initial observations. And our observations were that both amiodarone and lidocaine were somewhat better than placebo, arguably marginal clinical significance or statistical significance, but the point here is that we got different results in a large randomized trial compared to a small randomized trial. So I'm a little skeptical, if you like, of initial observations. Good hypotheses, but we have to be careful before we say, aha, this will work in all patients at all times. I am most particularly phobic about translating the results from observational trials to clinical practice. There are oodles of examples all over medicine. I'm just going to give you some little snippets, some from the world of vitamins, because I have a pet peeve, which is vitamins to improve human health without proof, and also from arrhythmia work. Let's start with the vitamins because they're of general interest. I have no particular expertise in vitamins, except I have some allergy to observational trials. You all know that consistently observational trials for 30 years have shown that people who take patients or individuals who take vitamins of any kind, vitamin C, vitamin D, vitamin E, you name it, live longer than patients who don't take vitamins. That's absolutely well documented. The question is this because people who take vitamins are in general healthier than people who don't take vitamins, or is it that the vitamins themselves are protective? And now we're talking about $20–30 billion per year worldwide of vitamins taken by all of our patients and by your patients, and patients will tell you if you take a careful drug history, they not only take prescription drugs, 3/4 of your patients are, they may not tell you unless you ask them, they're taking something, fish oils, various vitamins. This is the bottom line. Again, I don't want to belabor it. Vitamins are not only not helpful, but may be dangerous. There's a signal for increased mortality from all of beta carotene, vitamin A, vitamin E, vitamin C, and selenium, the best things you can say for them that they don't kill people. Recent study in 2022, vitamin D on bone fractures. Long story short, not effective. Don't use vitamin D to prevent fractures. I have no data on avocado, but those of you who like avocado in your salad, this is the kind of stuff that your patients are reading, and many of your colleagues are reading, and you are reading. And the bottom line, I hope you share my skepticism that eating an avocado a day will make you live longer, but this is the stuff that you will read. High avocado intake was associated with a low risk of cardiovascular disease. Final statement, the replacement of certain fat-containing foods with avocado could lead to lower risk of CVT. My reaction is, are you kidding me? Avocados are tasty, by the way. Great. I have a recipe for avocado salad. I'll share it with anybody at the end of the talk. So beware of bias in open trials. This is going along with sort of observational trials. We did a trial called VPS1 in the Canadian community. Dr. Green will remember this trial. We took patients with vasovagal syncope who have demonstrably bradycardia and hypotension. That's vasovagal syncope. You all familiar with it? Not everybody, by the way, with vasovagal syncope has bradycardia. Some have heart block, some have sinus bradycardia, some have a failure to have appropriate sinus increase, but you see somebody who's unconscious and their pulse rate is 55 or 60. And they're unconscious because they have no detectable blood pressure, and that's because they have vasodilatation. So the reflex involves both vasodilatation and sometimes bradycardia. So the thinking was, not inappropriately, some of these patients are bradycardic, let's give them a pacemaker and they won't have bradycardia. And we further used to do tilt studies in those days. We looked at tilt-induced syncope where patients fainted on the tilt study and they have had a heart rate of 10 on the tilt table. And we said, aha, this is now not the same as spontaneous vasovagal syncope, but that's bradycardia. Let's give them a pacemaker. This is before all of these trials. And we found that, yes, pacing works beautifully. And then we ended up doing a trial called VPS2, which was a blinded sham-controlled trial, and it no longer worked. So I should have been talking to this slide. Basically, what was found, the VPS2 is here. It's in very small print. You can see it at the bottom. But let's look at these first. These are trials where there was an open comparison of pacing versus no pacing, dramatic benefit of pacing, meaning patients with a pacemaker fainted much less. This is recurrent syncope with prior syncope. Put in a pacemaker, patients stop fainting. 80%, 90% reduction in syncope incidence. Second set of studies where there were different kinds of pacing comparisons, dual chamber versus single chamber, rate responsive versus not rate responsive, same thing. Fancier pacemaker technologies lead to much less syncope than less fancy pacemaker technologies. But then the question became, and I take some credit for this idea, working with Stuart Connolly and others, we said, well, could this in part be a CNS effect, a treatment expectation? I don't want to call it placebo because there's a device implanted here. Let's call it treatment expectation effect. And in this last set of studies, which is SynPace and VPS2, what was done is patients who had the syndrome of recurrent vasovagal syncope all had a pacemaker implanted. Half of them had the pacemaker turned off. The patients and the caregivers, meaning the personnel in the pacemaker clinic, were blinded. In other words, we had no idea. We went through all kinds of hoops, basically, to make sure that we weren't in the room when the patients had their pacemakers, like the caregiving docs in the pacemaker clinic, weren't in the clinic. The patients went to a different clinic, had their pacemakers programmed on or off, and they were seen and followed up by other kinds of doctors, not the investigators. So as best as we could, it was like a sham surgery control. Patients had a pacemaker turned off compared to patients who had a pacemaker turned on. And guess what? Everybody had a reduction in pacing. It's not that pacing is ineffective. It's that pacemakers turned on were not better than pacemakers implanted turned off. So the act of putting in a pacemaker, obviously not something you want to necessarily do for syncope, has a very powerful effect on this particular condition called vasovagal syncope. Now, I don't have time to talk about tons of data suggesting that sham surgery, this is in fact sham surgery, has shown us that knee surgery for individuals with chronic osteoarthritis not knee replacement, but meniscectomy and cleaning out the knee, ineffective. Back surgery, ineffective. Injecting dopamine into the brainstem, ineffective. Laser revascularization for cardiac surgery, which was in vogue, and lots of institutions. I don't know if you spent the money here, but in Toronto, we spent, I don't know, $500,000 on our laser revascularization device. Complete waste of money until the sham surgery, renal revascularization for hypertension. As best as we can tell, most of the benefit is a placebo benefit. So when you have surgical or non-blindable type of outcomes, we have to be very careful to separate true treatment effect from treatment expectation effect. The other aspect of presentation of research data that I don't want to say skeptical about, it's not skepticism here, that may be the wrong term, but we have to be careful in interpretation, is confusing relative effects to absolute effects. The advice I have to all my young colleagues is if you see a paper that has odds ratios or hazard ratios, I mean, there's millions of papers like that. If the paper does not tell you what the absolute effect size is, close it and go have a beer. All right? Because you have no idea. It may be true that the relative effect is real, but without knowing the absolute effects, you as a caregiver and your patients cannot interpret what you should do with that data. I'm going to pick a topic that's favorite for me because I like drinking alcohol, is alcohol and atrial fibrillation. So this is the kind of stuff that your patients are, and now it's a big deal because government of Canada is now coming up with labels on wine bottles saying alcohol causes disease. I'm just not going to talk about it. I'm not talking about alcohol and suicide and alcohol and homicide and alcohol and driving. Alcohol excess is terrible. Alcoholism is very bad. So please don't misunderstand me. I'm talking about what's the phrase? Sort of everyday use of alcohol, not problematic alcohol use in your patients that have heart disease, particularly atrial fibrillation. Because there's a meme out there, partially correct, that alcohol in excess does lead or contributes to atrial fibrillation. Hundreds of papers. But now let's look at the absolute versus the relative. This is one such example from 2017. You can see that there's a graded increase in the risk of developing atrial fibrillation as a function of alcohol intake in units per week, and the risk is somewhat low at low doses. This is a recent paper, which I think is interesting because it also tells us about the genetics of atrial fibrillation. It's a very large, extremely well done, careful longitudinal study by our British colleagues. They looked at associations between a variety of behavioral and genetic factors and disease. And one of the things they looked at is polygenic risk scores for atrial fibrillation and the effect of alcohol intake. Without getting into the complicated discussion of how reliable is self-report for telling you how much the patients are actually drinking, let's just assume that our patients are accurate in their self-report of alcohol intake. They may not be. And what they looked at was, and so some of this is the spin discussion and some of it is the absolute discussion. So what they found, first of all, is they arbitrarily divided patients into the tertiles of polygenic risk score. I can't tell you what the genes are. There's a whole bunch of genes. It's all empirical kind of stuff. What are the risk scores for developing AFib in the first place? Controlling for hypertension and diabetes and overweight and valve disease and all the kinds of things that we know are associated with atrial fibrillation risk. So they controlled for all that stuff. And they showed that there are some patients at low risk for AFib. Just ignore the two squares just for the moment. All of these patients are in the low tertile of polygenic risk score, and these patients are in the higher tertile of polygenic risk score. And then they looked at what they called acceptable amount of alcohol, which is 1 unit per day. That's 1 beer or 1 glass of wine per day, arguably relatively modest alcohol intake. And you can see that for 2/3 of the population, there is no relationship of alcohol to atrial fibrillation risk. In the highest tertile of risk score, that's 1/3 of people, arguably a large number of people, there is a definite increase in the risk of atrial fibrillation if you have this particular set of genetic predispositions. And this is drinking more than a drink a day if you're a woman, or more than 2 drinks a day if you're a man. And this is their consumption. This is their conclusion. Preventative efforts focusing on minimizing alcohol intake may be broadly applicable. Now, I think we can all agree that if you're a problem drinker, you should minimize your alcohol intake. But we're not talking about problem drinkers. We're talking about, yesterday I had a phone call from the son of a patient that I recently saw in hospital with AFib. This lady is 91 years old, and she would like to have a glass of wine with lunch. She's Italian, and he says to me with some embarrassment, it's just an anecdote, this is from 2 days ago, from Friday, he calls me and he says, you know, my mom likes to have a glass of wine at lunch, but she's been told and she's feels that glass of wine is dangerous. Of course, what was I going to say? She's 91. Of course, have a glass of wine at 2, at 3. Give me a break, right? But this is what your patients are thinking. But now let's look at the absolute risk, not the relative risk. So I'm using their data. I think it's exaggerated, but I'll just use their data anyway. I calculated from their data, from their observed incidence of atrial fibrillation, the observed alcohol intake, and their observed published data. You can see at the bottom here that 1 extra drink a day, up to a fairly large amount of alcohol, increases your risk of AFib by 2 events per 10,000 patient years. Somebody said to me, the price of my having a beer with Dr. Green, well, the price is, of course, I'm always paying because he's a better golfer than I am, but that's a separate issue. We're going to leave that aside. If somebody says to you or your patients, can I have a beer, doc, or can I have a glass of wine with dinner? And you know that they're increasing the risk by 1 drink a day of 2 per 10,000 per patient years, the answer is, give me a break. Of course, I'll have the wine or the beer. So the absolute risk is much more important than the relative risk. There's a big deal in the sports literature. In fact, there's a whole chapter in the European Society guidelines on atrial fibrillation and avid sport participation, particularly endurance sport. You'll notice the Dorian's rule here. I take some credit for that. For those of you who have more than 3 bicycles, sell one because you're going to get AFib for sure. This, by the way, does not apply to aluminum bicycles. So if you have unobtainium bicycles, just buy a cheaper aluminum bike and you'll be fine. Because I have lots of discussion about that. Your patients, trust me, those patients, and there's many more of them than there used to be, who are avid cyclists, who are avid endurance athletes in middle age. And what they are reading is that endurance sport, marathons, triathlons in Canada last year, there were 150,000 people who finished a marathon. So your marathon runners, if they go on blogs and Twitter feeds and go on the internet, are going to believe that atrial fibrillation is caused by marathon running, which is probably true with a risk ratio in the most fit individuals of 1.3. But I'm just showing you the slide because if you look at it in men, age is the most important risk for AFib. And these are individuals who've completed a 120-kilometer cross-country race, whether they're winners, which is the fastest. These are people who are training 2-3 hours a day, all in Sweden, and versus low risk. There's a barely perceptible delta of risk between non-skiers and the most avid, serious, competitive endurance athletes. It's true, but as an absolute value, it's meaningless. Interestingly, in women, this is just a little side issue, but I think important. In women, there is no upper limit of sport or exercise that contributes an increased risk of AFib. It's protective all the way down the line, doesn't matter how much you train. So women seem to be immune from this small, real, but tiny increase in risk from long-standing competitive sport. So in theory, there's no difference between practice and theory, but in practice there is. Let's talk about practice. This is practice. A Canadian guidelines suggest, and here I know I'm going to be on slightly thin ice. What I'm about to show you is probably controversial and not intuitive, and not everybody will agree, but let me try this on with the group for size. Our Canadian guidelines say that if you have rapid ventricular rates in atrial fibrillation and well-preserved ventricular ejection fraction, I'm not going to talk about heart failure patients where it's pretty clear if you have heart failure, you should be on a beta blocker, lots of good studies, although we can talk later about the subgroup of patients with AFib who also have heart failure with reduced ejection fraction. Let's just talk about people with well-preserved EF, which is a vast majority of individuals with AFib, persistent or permanent AFib. Canadian guidelines recommend beta blockers or calcium channel blockers, rate slowing, so-called non-dihydropyridine calcium channel blockers. I can tell you in practice, in Canada and the US and in Europe, about 80 to 82% of all prescriptions for rate control are for beta blockers. 16% are for calcium channel blockers, and 2% are for DIG. That's the consensus in the community. And the guidelines, I think, appropriately say one doesn't work, try the other, and try digoxin if these drugs don't work. But let's actually look at the data that helps support. I'm not saying that these drugs are not effective, but let's look at the data that support the belief in the superiority of beta blockers, to the extent that we agree that if beta blockers are the drugs that we all use for rate control, presumably we think they're superior for some reason. The bottom line is they are superior for the cosmetic outcome of slowing ventricular rate. They're not superior for the patient outcome. Let's look at the data. This is old data, and I could show you half a dozen or a dozen papers, all from the 1980s, looking if in a placebo-controlled paradigm at the exercise capacity and ventilatory reactions to beta blockers versus calcium blockers. I'm just showing you one example for the sake of brevity and for the sake of time. This is a study where they looked at celiprolol, which is not frequently used, but it's a beta blocker. It's very effective, both at patient perception of effort and rate, and I'll show you max VO2 in a second. So both diltiazem and celiprolol, let's look at the right-hand panel first, are more effective than placebo at reducing heart rate. So this is heart rate through exercise. You can see that with beta blocker or calcium blocker, the heart rate is slower to begin with before the stress test in a controlled setting, and the maximum heart rate is substantially reduced. With celiprolol here, it's about 120, which is kind of what we expect from a good dose of beta blocker, versus 180. These are young, healthy people. These are not patients with AFib. Now we look at patient perception. We can see that as you exercise, this is VO2 as a measure of oxygen consumption. As you continue exercise, you make the assertion to the investigators, I'm working harder, I'm short of breath, I'm tired. And as you continue exercising, the curves diverge, and patients on beta blockers feel like they're working harder at a less exercise capacity and at slower heart rates than patients not on beta blockers. And patients will tell you, if you ask them, when they're exercising vigorously on a beta blocker. This, of course, may apply less to an 85-year-old with atrial fibrillation that's kind of not very active, but it applies to a lot of your atrial fibrillation patients that are athletes or younger in their 60s or 70s and want to keep doing sport. They'll tell you they feel like they're running through molasses. And we look at, this is sort of the bottom line of the study. This is anaerobic threshold. Make a long story short, this is their conclusions. Beta blockers lead to increasing air hunger at any level of exercise and any heart rate. And the max VO2 is depressed by beta blockers. So beta blockers impair exercise tolerance. Lots of other data suggesting that at best they're neutral. Calcium channel blockers are either neutral or improve exercise tolerance. So that makes me a little skeptical about beta blockers as the go-to drug for atrial fibrillation. Fast forward to 2020. Let me spend a little time on this because this is not necessarily intuitive. And this goes against the grain of common clinical practice. This is what a study that, in my opinion, has received insufficient attention in the literature, but it's a well-controlled, randomized, not blinded, to be fair, trial. These are mostly older individuals. It's hard to see from the back, but their average age is about 75. They're about half women. The ejection fraction was normal in just about everybody. Mean EF was 52. There's a high proportion of HFpEF in this population, lots of dyspnea, lots of hypertension, and they had atrial fibrillation. And at the beginning, the average heart rate was about 100 per minute in persistent atrial fibrillation, randomized to bisoprolol versus a digoxin. Bottom line, the main conclusion of the study is that the SF-36, which is a commonly used measure of integrated quality of life, was not statistically significantly different between beta blockers and digoxin. But if we dig a little bit deeply, and I confess here I'm a little bit biased in favor of digoxin based on largely of the study, so I'm going to encourage us to look a little more carefully at the data. We can see that roll physical, which is a subjective measure of what going to the store and climbing stairs and doing gardening and etc., is significantly better on digoxin than bisoprolol. Global health, subjective measure of how the patients feel, better on digoxin than bisoprolol. New York Heart Class, now this is the doctor's measure of how the patients are doing, better on digoxin than bisoprolol. That's New York Heart Class. And NT-proBNP, which is an objective measure, gets worse. Now, admittedly, the deltas are relatively small, but for whatever it's worth, NT-proBNP on the average goes up with bisoprolol, and on the average it goes down with digoxin. And the difference in differences is highly statistically significant. Importantly, and this is something that's often ignored, it's not ignored by you as caregivers, but it's ignored in the large clinical trials. It's now look not just at the benefits of rate control and atrial fibrillation, but look at the downsides. And the downsides are side effects and doctor visits. We can see that in the bisoprolol group, out of 80 patients, there were 142 adverse events in 51 patients. With digoxin, there were 29 adverse events in 20 patients. So dramatic reduction in adverse events in digoxin. Fatigue, dyspnea, lassitude, sleep disturbance, cold hands and feet, sexual dysfunction, all of the above. Which leads me full circle back to observation versus clinical data. There are 100 papers in literature, maybe more, that make the assertion that digoxin is a dangerous drug, that it promotes sudden death, and people on digoxin have worse outcomes than people not on digoxin, almost entirely from uncontrolled observational trials. And they tried to control for the other variables. So what Dr. Davila and colleagues did is something very clever. They said, let's see if we can figure out, this is now the comparison between observational and clinical trial results. Let's see if the concept of propensity matching and of retrospective matching for equal risk, let's see how good that concept is. You're familiar with propensity matching, which is using observational trials, going back and saying, can we do a quasi-experimental design from observational data by finding patients who get treatment A and finding similar patients who got treatment B, because maybe there's physician-determined biases as who gets which treatment. So they went back to the DIG study and they took advantage of an interesting sort of historical observation. About half of the patients in the blinded randomized trial of digoxin versus placebo in heart failure. So I'll just remind you, the DIG trial, there was a blinded randomized large-scale study. It showed that digoxin versus placebo did not increase mortality, did not decrease mortality, it was neutral, but it reduced heart failure hospitalizations. So arguably of some benefit, okay? That's digoxin placebo-controlled randomized. Now, it turns out that prior to the DIG trial, same patients, half of them were on DIG and half of them weren't, okay? So they were sick enough to require DIG, and if they got randomized to placebo in the DIG trial, the DIG was stopped. So some patients started with no DIG and got randomized to DIG versus no DIG, and some people started with no DIG and got randomized to DIG versus no DIG. And what you can see here in the blue is the original RCT results. What you see here in the red or the yellow is with or without secondary controls for other kinds of variables. You can see that the patients who were previously on DIG, they got randomized to placebo, had a much worse outcome than patients not on DIG who got randomized to placebo. It's a placebo-placebo comparison. What this is saying, understandably and logically, is that whether you control for these variables or not, is that if you use the observational approach and say, aha, DIG is bad for you, it's bad for you because sick patients get digoxin, and you cannot control for these variables, right? This is controlled for and not controlled for. So what they're teaching us is the whole business of trying to understand what a randomized trial would have told us by controlling for these other variables is fraught with risk. Plus, it's also telling us that DIG maybe is not as bad a drug as we used to think it is. Bottom line here, I apologize for repeating myself, is be very careful on how you interpret observational trials, even if they've gone to great lengths and enormous sophistication of controlling for these so-called confounding variables. And this is because of our expectations. So which line is longer, do you think? Segment A or segment B? Dr. Beelance has been reading, but it's hard to convince yourself. I mean, imagine you hadn't read the literature that he's read on prospect theory, because he's brilliant, as we all know. The top line looks longer than the bottom line, doesn't it? I think we can all agree it looks longer. And now I've drawn a line, and of course they're all the same, but it still looks longer. This is just a primitive demonstration of, even when the evidence is staring you in the face, that the two lines are of equal length. You have to really work at convincing yourself, at least I do, maybe my eyesight's bad, it is, but I have to convince myself that the top line is not longer than the bottom line. Human perception, we're very fraught, to be biased, even when the evidence is right in front of us. Let me just spend 10 minutes on the work that I've been doing for the last 10 years or so. I've become increasingly interested in the ability of caregivers, of us as caregivers, to understand what patients are thinking. So now we're going to talk about communication. Much of this is observational, so please forgive me for that, but I think some of it is evidence-based. I think we can agree that we all believe that if a patient has been to an emergency room with atrial fibrillation and has prior history of atrial fibrillation, and they get appropriately treated and they go home, that they will understand something about their disease. I have to tell you, that was my belief. This is work that has not yet been published or presented. It's going to be at the CCS this year. It's one of our cardiology residents from the U of T who's presenting this poster. So what we did in terms of what we think patients are thinking is we had a research coordinator, wasn't one of the investigators, a psychologist, phoned patients at home 6 weeks after hospital discharge from uncomplicated atrial fibrillation and asked them a series of questions with a scripted interview. But amongst the questions were, what do you think would have happened if you hadn't gone to hospital? And these are patients that we think are educated, right? What do we think happens to patients if they have atrial fibrillation? They get palpitations, they get sick, maybe they get dyspnea, maybe they go to a little bit of heart failure. But do we think that AFib causes death or heart attacks? I don't think we think that. Here's what patients think. 84% of the patients think they know something about AFib. 23% of them go to hospital, not because of palpitations, but because of fear and anxiety. Almost half of them, 43%, felt that the reason they must go to hospital because of AFib, and these are educated patients. These are not patients with first ever AFib. These are patients that had 80% of them had prior episodes of AFib, and they've all been to hospital and have seen doctors. Despite that, 43% of them believe that if you have AFib, you in the next hour, you will have a stroke or die or have an MI. Most of them believe they would have multiple of these outcomes. So unless you ask patients what they're thinking, you may not know. George Bernard Shaw, as usual, was way ahead of us when he said the single biggest problem in communication is the illusion that it has taken place. So you think you're instructing, you think you're teaching your patients, but don't be so hasty in that conclusion. So we think that ICDs save lives. Sounds pretty straightforward. Absolutely they do. This patient, we would make the assertion the ICD has saved their life. Not so fast. What's obvious is not necessarily true. I'm not going to deny that defibrillators are wonderful technology. We use them all the time. But the question is, should we implant a defibrillator to everybody at high risk? And now we have some sobering data in 2022. This is an original trial that we did called the Dynamite trial, where we took patients that believed should be an absolute slam dunk benefit from defibrillators. Post-myocardial infarction, definite myocardial scar, big scar, ejection fraction less than 30%, plus low heart rate variability, which is a marker for high sympathetic tone. So the observational data suggested these patients had a 30% annual mortality rate, half of them dying from sudden death. So it seemed completely obvious that all these patients should get a defibrillator prophylactically. This is before the current era of primary prevention, or around the current era. I mean, paper was published in 2004, but we started the study in the late 1980s. And guess what? Patients who had defibrillators died suddenly much less commonly than patients who didn't have defibrillators. but they died more often from heart failure and recurrent infarction, largely from heart failure. So what you gain by the antiarrhythmic benefit, you lose. This is not necessarily because defibrillators are killing people, but we have an unexplained finding here. Patients with defibrillators, early after MI, primary prevention, have no change in mortality. The overall mortality is the same, but you trade off one kind of death mechanism for another kind of death mechanism. And when we published this paper, we were told the criticism was study's too small, not replicable, you're all idiots, you're Canadian. Well, the Europeans did it. Sorry, I didn't show you the paper. It's called the IRIS, same study, same result. So now we have two studies, two different continents, exactly the same results. Why should this be? So with the assistance of the group, I did a study looking at the potential mechanisms. And the bottom line is that the slides are a little bit small, but basically what we showed that the overall mortality was the same, but that if you had a defibrillator shock, then your chances of dying in the next 6 months were extremely high. If you had no defibrillator shock, then your chances of dying were the same as people who never got a defibrillator. So put it another way, what a defibrillator shock may be life-saving temporarily, but the very fact that you have an arrhythmia in this patient group identifies you as a patient who's at very high risk of dying from heart failure. So at most, defibrillators in these patients are postponing death by a few weeks or a few months. And when you follow them over 5 or 10 years, there's no benefit from defibrillation. Not because defibrillators don't work, but defibrillators are working in precisely those patients who are going to benefit the least in the long term because they're going to die from heart failure or die from recurrent infarction. And that's the conundrum of how could it be that such a demonstrably effective therapy, in fact, doesn't work in the big picture. It's an unresolvable conundrum, right? The people who have the disease are the people who are going to die from other things where the defibrillator no longer works. Getting back to the story, I don't want to get into the polemics necessarily for the sake of time of who deserves a prophylactic primary prevention implanted defibrillator. Now I'm going to talk about absolute benefits and spin. The Danish trial, which many of you are probably very familiar with, which is the largest ever trial looking at primary prevention implanted defibrillators in patients with non-ischemic cardiomyopathy. Its primary endpoint was reduction in mortality, not statistically significant. So no overall benefit from defibrillators in patients with non-coronary dilated cardiomyopathy for primary prevention. The investigators understandably tortured the data, and it confessed that if you're age under 70, there's a benefit. If you're age over 70, there's no benefit from defibrillators. This is now the 10-year follow-up, just got published a couple of months ago. Long-term follow-up, so arguably much better data. The all-cause mortality still not significant, to the extent that we believe that in younger patients, defibrillators may be indicated. Now, this is, I'll remind us, this is now a secondary analysis in a study where the primary analysis was not significant. Our statistical colleagues will tell us this is a no-no. This is hypothesis generating, not hypothesis answering. That's one possible problem with this. But even to the extent that we believe that in younger patients, primary prevention ICDs and dilated cardiomyopathies prolong life, question mark. Even to the extent we believe that, the absolute mortality benefit, which I calculated, which is not mentioned anywhere in the Danish paper and not mentioned anywhere in the 10-year circulation high-quality journal, zero absolute benefit calculation. I did it myself, and it's 0.6% per year mortality benefit, even if it were true at age under 70. Now, we can argue that 0.5% per year reduction in mortality is worthwhile or not worthwhile to spend the money and the effort and the surgical time to put in a defibrillator. But remember, the risk of serious complications from a defibrillator is not negligible. That's a pretty small absolute benefit. In my argument, insufficiently discussed, even to the extent that the sub-analysis is true. Here's the spin. This is from the paper. Until more data is available, ICD use for primary prevention should be individualized in patients over the age of 70. They're assuming that it's a slam dunk under 70, everybody gets an ICD. And they're saying over the age of 70, where it's malpractice to put in a defibrillator, you could make an argument that you should think about it carefully. Are you kidding me? If we're sober about the data. Now, I'm not going to tell you that in a 71-year-old, I would never implant a defibrillator with primary prevention. I'm just making the extreme argument, as befits a Hungarian skeptic, that we have to be very careful how we interpret this data. So I think that's spin. Let me just finish in the last, I'll take 5 minutes and we'll have time for questions, to talk to you about a mistake that I made in trying to understand patient-physician communication. This is the CCS atrial fibrillation scale. I was formerly of the belief, I still think it's true, but it's only partially true, that the best way to measure patient well-being in atrial fibrillation, and it's probably true in angina and heart failure and many other things, is to ask them about symptoms. And I think in that belief, I was wrong, at least incompletely accurate. The Canadian atrial fibrillation severity scale and the European scale is roughly similar, says you ask the patient about symptoms and you say, how much do your symptoms affect quality of life? Obviously, I think something we do every day and is worthwhile. The more symptoms you have, the more your quality of life is going to be affected. I have now come to believe that that is an incomplete assessment of what goes on in patients' heads. I think we didn't interpret the subjective correctly. And I think Aristotle tells us it's the mark of a trained mind never to expect more precision in the treatment of any subject than the nature of that subject permits. And I think we inappropriately said SAF 1, 2, 3, 4 is precise, and it tells us what we need to know about quality of life, and it doesn't. And this is totally hypothesis now, the next 2 slides I'm going to give you. This is just my belief. When we talk to patients, this includes atrial fibrillation, but it includes everything else. It includes heart failure, it includes angina, it includes any symptom you want in cardiology, it includes joint pain, you name it. What we're assuming is that what we have at the end of the conversation is a correct understanding of the patient's state. I think it's more complicated than we give it justice, because when we look at the quality of life questionnaires, we get the patient verbalization of their internal state. But that's complicated. Patients have to assess their internal state. Then how they describe it depends on their internal mental workings, which is going to be largely influenced by their culture, by language or language barriers, by their ability to express themselves, and by their prior experiences. There are lots of data for this, which I'm not going to bother you with, from these largely psychology and philosophy literature. And what we ask about is an expression of their internal state as written down on a questionnaire. So there's some limitations there. When you're a caregiver, you have the added problem of having difficulties in communication, embarrassment, language barriers, spouse in the room, spouse not in the room, you're in a hurry, they're in a hurry, et cetera, et cetera. So the medical record is very far away from the patient assessment of their internal state. This is patient complains of dyspnea, patient complains of palpitations. We should be assessing this, and instead we're assessing something with broken telephone that's many leagues downstream from what the patients are really experiencing. I have no easy answer to how to fix this, by the way. It's just something we should be aware of. So this is the concept that I now think about in terms of quality of life. I've kind of revised thinking about quality of life. It's really about communication. Many caregivers, many papers try to, or at least imply that atrial fibrillation burden is the good measure of quality of life from atrial fibrillation. I think we all know enough to know that some patients are in AFib all the time and have no symptoms. Other patients are in AFib infrequently and have lots of symptoms. So we've gone on appropriately and said, let's look at AF symptoms beyond just looking at the ECG. And we know that AF symptoms are not so simple because they're influenced not only by the amount of AFib and heart rate, they're influenced by, as we talked about, communication, comorbidities, heart failure, et cetera. But there's an added element, which I think in the last couple of years, I've learned to respect and understand and consider more important than I used to, which is the patient underlying mental state, which has important influence on their symptoms. This is the so placebo effect, if you like, or nocebo effect. And I think AF psychology, you've all seen patients who have AFib infrequently, but every time they go into AFib, they go berserk. They call you on the phone, They run to an emergency room. They refuse to get on a bus or on a plane or on a cruise ship because they're afraid if they get AFib, they're going to die. So I think what we should be thinking about is how do we assess integrated quality of life? Again, I have no easy answer here, but I think it requires us not only to be electrophysiologists measuring AFib burden, but it requires us to be thinking about symptoms, and it requires us to be communications experts, psychiatrists, psychologists, caregivers. You can call it what you want, and understand the patient's underlying mental state. And I'm going to leave you with a quote from somebody that you've never heard about. It's Dr. Martin Green. Dr. Green has many laws. I'm taking, he's got many commandments. In fact, those of you know, not just laws, they're commandments. There are many, they're all fantastic. I urge you to look them up and he'll tell you. And I've taken the liberty of pronouncing that this is Green's law number 1. It's probably number 7 in his book, but I'll call it number 1. It's the single message I want to leave all of, especially colleagues at the beginning of their careers. When all else fails, talk to the patient. And if you talk to patients for long enough, you will develop insights that are much smarter than mine, but you're going to develop insights that you won't get from the medical literature. And lastly, let me just finish with the most important physician anywhere who gives us the most important information about how to embark on a career of research. And of course, that's Yogi Berra, who said, got to be careful if you don't know where you're going, because you might not get there. And if you don't know where you're going, you might wind up someplace else. Thank you very much.
Thank you, Dr. Dorian. I would request you to be at the podium. So
I'm not going anywhere. I'm going to stand in front of the camera here. That's one thing about virtual medicine. If you leave the camera, they think that you've disappeared.
If anybody in the room has a question, please come up to the mic. I don't see any questions online and no show of hands, but Dr. Liu is coming up and Dr. Bean.
Is this on or is this?
Yes.
Yeah, it's on. Yeah, great talk as always. In terms of particularly the philosophy, of actually, 2 things. One is actually, sort of looking at the data, right? With kind of a bigger eye than the data itself. And then the other aspect is the patient aspect. So right now we are actually doing a lot of work in terms of patient shared, research participation. We actually train our patients, to participate in different components. And it's amazing how much patient teaches us, the priorities we see, particularly in heart failure, hospitalization, deaths, and things like that. That's not actually what the patients are most interested in. Quality of life is the most important. They can take the kids, the grandchildren to school and things like that. So we really need to appreciate that. I think the beta blocker data is really fantastic. So the point I want to ask you on is the fact that single trial itself is quite artificial. We actually take a real world situation, dissect it, and then ask a single question. This is particularly for prevention trial, and I'm always struck by the fact that when you actually have a multifactorial intervention in prevention, the best is North Karelia project, in Finland, right? That's actually where we learned that diabetes, changing diet and all the rest, changed all the WHO recommendations is actually a multifactorial intervention. And so I wondered, whether we do these, single factor intervention in complex diseases, in fact, disadvantage ourselves and our patients and come up with a lot of negative results. But in fact, we actually put things together. And of course, we know this, from all the risk factors that we know, right? So I just wondered whether we are missing those opportunities, and you do need to actually, bring a lot of data together to actually, sort of look at what makes a difference.
Those are fantastic points. Thank you, Peter. I agree with you completely. I think what I can offer is, I'm afraid, because I can't make life simpler, I just can only make life more complicated for all of you. We have climate change, which is complicated, and this is complicated. What can I tell you? But I just point out some tensions that we have to think about. Whenever we do medical research, particularly large clinical trials, we always have a tension between what we call efficacy and what we call effectiveness. Efficacy is the kind of reducing all of the variables artificially, so that the only thing we're comparing is the drug versus the placebo, or drug A versus drug B. And that gives us as accurate as possible measure of the biological and potentially clinical effect of the single intervention. But single interventions, of course, never happen in isolation. They happen in a larger context. They happen in the context of the fact that not all patients participate in clinical trials. Clinical trials, as we, I think, understand now, are basically trials of well-educated, relatively middle class or upper class individuals who live in urban centers. If you live in Wawa, you're not going to get into a medical trial. If you live on the street, like people do right outside my hospital at St. Michael's, you're never going to get into a clinical trial. If you have cultural, linguistic, other kinds of deprivations, you'll never get into a clinical trial. So we're looking at a small microcosm of the population. As particularly true in heart failure, you know, many people in this room are much more expert than I am. It's a moving target. You know, heart failure trials from 20 years ago, we had different therapies. We had much less coronary disease. We had more Doritos, less Doritos, I'm not sure. But the point is population health evolves. So there's no answer here except we have to be kind of nimble and be aware of the fact that the landscape is constantly shifting. And what may have been true 20 years ago is not that the trial itself is disproven, although that may be the case. It's just the landscape is different. So the interventions that worked 20 years ago don't work today for other reasons, not because the intervention is no good. I'm sorry to make things complicated, but that's why all of you in the room that are under 35 after we're long dead are still going to have careers, because not all the questions are answered, believe me.
Yeah, thanks, Paul. Excellent. So insightful. As really my point was kind of similar to Peter's, that the clinical trials answering one specific question about one specific population. And we can't answer all questions. We just don't have the capacity to do that. And so we still have to rely on some observational data with our clinical decisions. And I guess your point is that may be the case, but we have to remain skeptical.
Absolutely. You know, and we have to look at, you know, I dissed vitamins a lot, but I have to tell you, if a patient comes in and tells me they're taking vitamins, I don't tell them to stop. I just say, okay, well, if that's what you want to do. I try to be honest and I say, I'm not aware of any evidence that any vitamins help you in any way, but if that's what you want to do, go ahead, because the risk is so very small. So yeah, we definitely, I mean, there's some things for which we have, for example, there's no good, we're now emerging clinical trials that treating morbid obesity is probably beneficial for arrhythmias. But if somebody has a BMI of 31, do we have proof that getting their BMI down to 26 is going to prevent AFib? Some, but not great data. Do we recommend it? Sure, we do, based on observation. You know, if somebody drinks alcohol to excess, I'm going to tell them, listen, it's probably a good idea if you drink a little less of it. So absolutely, we want to do sensible things based on observational data. We just have to be careful that we don't necessarily assume that all of these things are absolutely proven.
And then the other point on the patient is like really 75, 80, 90% of what we do and see is about the patient's reaction, their mind, their psychological state. You know, how they respond to when they get chest pain. Is it really cardiac? Is it not cardiac? Is it simply anxiety, stress, whatever? It's all real to them. That's what I say always. That symptom is real to you. It's just not coming from the heart, I don't think. You know what I mean? So we're dealing with that all the time. And we're not like you've had a long established career, and you're realizing some of this stuff now. We don't teach ourselves this well over time, and in medical school or anything like this. And so it is a concept that we need to try to enable better.
You're so right. You know, I mean, I came to some of these realizations over the last 10 or 20 years, but I'm in practice for, 40. So these things are not necessarily intuitively obvious, or put it this way, our medical education, at least in the past, this is now my belief, medical education in prior decades, I think no longer quite as true today, fortunately, has sort of de-emphasized these aspects of the patient experience, and something we have to pay sort of careful attention to. Absolutely.
So we have a comment and a question from Carolyn Pullen, who is a CEO of CCS. So she writes, sending thanks to Dr. Dorian from his colleagues at the Canadian Cardiovascular Society. As always, Dr. Dorian did a masterful job with a compelling topic. I have shared the lecture with my colleagues at CCS, particularly given the relevance of all we do together in CVD guidelines development. Thank you. And then she says, if you have time for another question, could you ask Dr. Dorian for any advice on how we can improve our processes for guideline development? Big question.
Yeah, difficult question. Two sort of observations. There may be many others. I am going to try to be brief. One is, I'm going to propose something that's really controversial. I think for every guideline, we should have two separate documents, sort of chapter 1 and chapter 2. Chapter 1 is only those recommendations that are based on one or more blinded or at least sham-controlled clinical trials, where we have sort of level 1 evidence. And that's chapter 1, where we have, I think, reasonable degree of confidence that this is true. Chapter 2 is everything else. Instead of having class 2A, class 2B, class 3 recommendations, all the hand-wringing that we do, all those of us who've been in guidelines trying to figure out where the evidence is, it's not that there's no room for expert opinion. There's lots of room for expert opinion. But I have a feeling that the medical community, particularly generalist physicians, get confused between class 2A and class 2B, and when is it class 1 and when is it 2A? And we have a page full of 37 recommendations. Some are class 1, some are class 2. I think we need to come clean as a community, and we need to say, this we are pretty confident is true. According to Joseph Ioannidis, I think John Ioannidis from Stanford, who's a world guru at sort of what is true, and he published this most famous paper, which I didn't have time to talk to you, called Why Most Research Findings Are False. He would say that if you have multiple large randomized clinical trials of some treatment, it's 83% likely to be true. Exactly how he comes up with that number. There's 4 pages of statistics. He says, if you have an animal experimental data, it's about 1% likely to be true, and so on and so forth. So I think we need to come clean. This is my advice to guidelines committees, and say, this is reasonably demonstrably factual. And then for those of you not interested, you can stop reading here. For those of you interested, all the rest is expert blah, blah. And class 2A, class 2B, it's all blah, blah. You know, believe me, I've been in the room and I've done the blah, blah, just like in many of you understand it. It's all blah, blah. Some of it may be true, some of it may not. I think we're not doing the community a service by pretending that it's all necessarily truth. The only other one quick things I would say is, I've done a lot of work with patient engagement and patient involvement. We use patients exclusively when we do quality of life, a questionnaire design. I am now, this is just in the last couple of years, I've come to be suspicious of that process. And I think the reason is, this is a hypothesis, is that when we involve patients, which we should, absolutely should, we involve highly verbal, experienced, intelligent, they're not regular patients. In our AFib studies, we have patients in our committee. They know more about AFib than I do. That's not the typical AFib patient, right? How do we solve that? I have no idea. We need to find AFib patients that are like my patients or our patients in our research study who have no clue. They're more representative of the general population. But how we do that, if you can tell me, please do.
So there are no other questions online. So I'd first like to thank Dr. Paul Dorian for taking time and refusing to come last year online by Zoom, because he directly wanted to interact with all of us. So thank you for your patience in accepting the Marr lecture this year, and for taking the time to teach us and educate all our residents. It was well received by all of us. And next, I would like to thank Mr. Marr for his benevolent support of research education in a very selfless way over the years. We're very thankful, Mr. Marr. And then to some unsung heroes, I mean, Mary Sullivan, she's standing there. This was entirely organized by her and her colleagues, Leanne Lang in the, our board, and all the audiovisual team, the research services, all of whom are not here. But I would like to thank them because these events would not occur without their, stellar work behind the scenes. So thank you, Mary, and your team. And now I think I'll request Mr. Marr and Dr. Green to give Dr. Dorian a small memento for and thank a token of our appreciation. Mr. Marr.
Can I come up, Paul? Perfect. I'm gonna stick around for thanks so much. Oh, yeah.